We described the pharmacokinetic and pharmacodynamic properties of antibiotics used for pneumonia. Now, let's distinguish between various types of pneumonia using patient-specific factors, clinical manifestations, and diagnostic testing. Here are some key definitions that you should know. So, by definition, pneumonia is a new lung infiltrate on the chest X-ray plus clinical evidence that the infiltrate is of an infectious origin. Now keep in mind that while this is the standard definition of pneumonia, for many patients, pneumonia is a clinical diagnosis. Now, generally speaking, there are two types of pneumonia patients. There are community dwelling patients, which means that there are patients who are not hospitalized, so they are residing in the community, and that consists of community-acquired pneumonia and healthcare-associated pneumonia. So these two types of pneumonia patients actually reside in the community. Whereas we have nosocomial pneumonia, and patients with nosocomial pneumonia will be residing in the hospital. So the two types of nosocomial pneumonia are hospital-acquired pneumonia and ventilator-associated pneumonia. Now, by definition, community-acquired pneumonia is pneumonia that occurs outside of the hospital. Even if a patient gets hospitalized and if the pneumonia develops within the first 48 hours of hospitalization, it is considered community-acquired pneumonia. And that's because there's an incubation time. For bacteria to grow and cause actual infection, it typically takes some time. So if pneumonia develops within the first 48 hours of hospitalization, that means these bacteria have already been growing. So the origin of these bacteria are from the community, not from the hospital. Whereas when you look at hospital-acquired pneumonia, it occurs beyond the 48 hours. So if the pneumonia occurs after 48 hours of hospitalization, it means that the origin of the bacteria is from the hospital. It's unlikely to be from the community. Now, there's also ventilator-associated pneumonia, which is basically beyond 48 to 72 hours, so at least 48 to 72 hours after intubation. So, if it's, pneumonia 4 days after intubation, it's considered ventilator-associated pneumonia. Now, keep in mind that all ventilator-associated pneumonia patients are actually hospitalized. So, VAP is a subset of HAP. But when you, diagnose a patient with pneumonia due to ventilator, we are not going to call it HAP. We actually call it VAP, even though those patients technically meet the definition of hospital-acquired pneumonia. So these are the three types of pneumonia that we will focus on. There's also healthcare-associated pneumonia that was part of the 2005 guidelines. However, the 2016 guideline removed HCAP from the guideline, and I will explain more on why that is. There's also aspiration pneumonia. Anytime a patient aspirates oral flora and those flora make it to the lungs, it can actually cause aspiration pneumonia. And these are typically due to anaerobic organisms. And by anaerobic, we're talking about Prevotella or Peptostreptococcus and things like that. We are not referring to Bacteroides or Clostridia species. Another thing that can happen due to aspiration, it could be a sterile aspiration. So it could be just gastric content without flora. And it can still cause some inflammation and reaction in the lungs. And we definitely call this aspiration pneumonitis rather than pneumonia. And some people call it chemical pneumonitis to make it clear that it is not due to organism. So aspiration pneumonitis or chemical pneumonitis should not be treated with antibiotics. Now, these are the criteria from the 2005 ATS-IDSA guidelines for diagnosis of HCAP. So you can see that, if the patient meets one of these 6 criteria, they will be considered HCAP. And the reason this was significant is that, if the patient has healthcare-associated pneumonia, they are more likely to have organisms that are multi-drug resistant. Now, the issue with this is that it's controversial because at least one study shows that specificity of these criteria was about 48%, 48 to 49%, and 1 out of 3 patients were misclassified as having multi-drug resistant pathogen. So really, it leads to over-treatment of patients, and that's not good because over-treatment can also have, like toxicities and selection for more resistant organisms. So the 2016 IDSA guidelines for HAP and VAP actually removed the term HCAP. The 2019 IDSA guidelines for CAP actually did not include HCAP, and they said that they actually recommend abandoning the use of HCAP in order to select patients who need extended antibiotic coverage. Instead, they recommended that clinicians only cover empirically for MRSA and Pseudomonas in adults with CAP only if there are locally validated risk factors for either pathogen. Now, pneumonia in general is characterized by a newly recognized lung infiltrate on chest radiograph together with clinical symptoms. So the common symptoms will be fever, cough, sputum production, shortness of breath, and leukocytosis. Now, some patients can also have confusion and pleuritic chest pain. Now, there are some challenges in diagnosing pneumonia. For example, some patients, especially elderly patients, may not cough or produce sputum, or they may not have elevated white blood cell count. And some patients may not have a fever. Another issue is that it's hard to interpret the chest x-ray, especially in patients with chronic lung disease like COPD, patients who are obese, and patients who get the portable chest x-ray. So portable chest x-ray is the x-ray that's done at the bedside, usually because the patient is not able to move. So if the patient cannot go to the lab to get the x-ray, they will bring a portable x-ray to the patient room. And of course, even when you do have high quality chest x-ray, that infiltrate could be due to different causes. So for example, it could be just aspiration pneumonitis, it could be atelectasis, it could be fluids from either heart failure or cirrhosis, or it could be pulmonary infarction.